Hi, I'm Kevin Tran, and I'm going to be answering the questions for case connection number 2. I am going to be going over cases number 3 and number 4. So, starting with case number 3, a 5-year-old boy presents to his pediatrician's office for an annual visit, and his mom complains of symptoms which include drowsiness, persistent thirst, and frequent urination. At the office, blood samples are taken at separate intervals, separated by glucose loading, um, in order to evaluate insulin levels pre and post loading. And, based on the patient's history and these findings, we are then asked to answer the following. The first question is in regards to the underlying biochemical basis for the patient's condition. So the patient's baseline serum insulin levels compared to the control are drastically lower. Um, Additionally, with glucose loading, the patient's insulin levels remain drastically lowered compared to the control. This would suggest that the patient's ability to produce insulin is limited, which would suggest that they have type 1 diabetes. Additionally, the patient presents with general lethargy, persistent thirst, aka polydipsia, and frequent urination, polyuria, which are clinical symptoms that correlate with the diagnosis of type 1 diabetes. His general lethargy is likely a result of malnutrition, as his body is unable to readily metabolize free blood glucose. Um, his frequent urination can be explained in that large amounts of glucose need to be ejected from the body through the kidney. And this increase in the number of solutes also drags out water via osmosis. And as a result of this frequent urination, the patient also develops, secondary polydipsia as they're chronically dehydrated from their constant urination. In regards to the patient's fasted blood glucose levels, I would expect them to be above the normal range that is typically found in normal functioning children, due to the fact that he is unable to process glucose given he has a lowered amount of insulin. Um, Normally, free blood glucose would be taken up within a cell via glucokinase or hexokinase. The aforementioned enzymes would phosphorylate glucose, turning it into glucose 6-phosphate and allowing it to enter the cell. Glucokinase and hexokinase activity are reduced as their level of activity is stimulated by insulin. In regards to the regulatory enzymes that are present in type 1 diabetes, the relative activities of enzymes involved in glycolysis and glycogenesis are impaired as a result of decreased levels of insulin, and as a result, the activation of enzymes responsible for gluconeogenesis and glycogenolysis are increased as a result of glucagon signaling and lack of insulin signaling. Two of these regulatory enzymes that are likely to be active in the setting of type 1 diabetes includes pyruvate carboxylase and glycogen phosphorylase, which are responsible for beginning gluconeogenesis and glycogenolysis, respectively. Inversely, I would expect glucokinase and glycogen synthase to be relatively inactive in glycolysis and glycogenesis. And that concludes my interpretation of case number 3. So moving on to case number 4, essentially a 2-month-old female presents with jittery spells several hours after breastfeeding. According to the baby's mother, this is the only thing she eats, which is a very important piece of her history. So following her feedings, the baby then only sleeps for 2 hours until experiencing the aforementioned symptoms. Subsequent laboratory testing then demonstrates findings consistent with hypoglycemia, and upon administration of epinephrine, there's no increase in blood glucose and an increase in blood lactate. We are also told via physical exam that she presents with the liver edge 4 centimeters below the right costal margin, which I presume indicates some sort of abnormal growth, given that we were also told that she presents with hepatomegaly. Lastly, we're told that she is unable to maintain regular blood glucose levels during a fast. So, with all of this information, we are then asked to determine the likely diagnosis, and we are given the following options: hereditary fructose intolerance, galactosemia, glycogen storage disease, and glucose 6 phosphate dehydrogenase deficiency. So, after reviewing all of the options, I decided that the patient most likely has glycogen storage disease. Based on the patient's history, she is symptomatic following a feeding session, meaning metabolically she is in a fasted state while she is exhibiting her symptoms. This points to a fasting state metabolic dysfunction. This is further supported by a laboratory testing where she was also found to be hypoglycemic. Additionally, the fact that her glucose levels are normal following a fed state and are below the normal range during a fasted state further points us in the direction of abnormal fasting metabolism pathology. Further evidence to support this diagnosis is the fact that administration of epinephrine failed to result in an increase of blood glucose levels. In healthy individuals, epinephrine should result in the activation of glycogen phosphorylase, which is the rate-limiting enzyme involved in glycogenolysis. Lastly, hepatomegaly, confirmed via the physical exam, is consistent with glycogen storage disease, as an enlarged liver indicates excess amounts of glycogen deposits on the liver itself. So moving on, I'm going to start ruling out the other options. There's no suggestion for galactosemia, as the patient is able to tolerate breast milk, which is primarily composed of lactose, which in turn is made up of glucose and galactose. If the patient did have galactosemia, it would have resulted in other symptoms, including, lack of energy, diarrhea, vomiting, and jaundice. And, additionally, these symptoms would have been present very early on in the patient's life, as an intolerance to galactose would have been immediately noticeable. But, she presents to the ER as of today's visit at the, age of 2 months. So in regards to glucose 6 phosphate dehydrogenase deficiency, there's no indication that her issues are a result of pentose phosphate pathway dysfunction. And instead, her issues are more in line with dysfunction of the ATP producing metabolic pathways. If the patient were to have some sort of glucose 6 phosphate dehydrogenase deficiency, they would present with symptoms more consistent with hemolytic anemia, which include but are not limited to jaundice, skin paleness, dark-colored urine, fever, weakness, tachycardia, and among other things. Additionally, glucose 6 phosphate dehydrogenase deficiency is much more common in males, and it's an X-linked recessive disorder, and the patient is female, so the likelihood of that is much lower. And then lastly, hereditary fructose intolerance can be ruled out. So it may, on the surface, it may seemingly be a viable answer given that the patient is hypoglycemic, which is consistent in, hereditary fructose intolerance. And additionally, they also present with hepatomegaly. However, if we look at the patient's history, they never ingested any food that might contain fructose, as according to the mother, the baby is strictly on a breast milk diet. And additionally, the patient does not present with any symptoms classically associated with hereditary fructose intolerance, which include but are not limited to nausea, bloating, abdominal pain, diarrhea, and vomiting. And that pretty much summarizes why those answers are incorrect. And then, one last thing of note that I thought was interesting was, we're presented with the physical exam findings for hepatomegaly. But, as I was going through these answers, the value in that piece of clinical evidence for, providing differential diagnoses was kind of unimportant, as hepatomegaly also presents in galactosemia, glycogen storage disorder, and hereditary fructose intolerance, which I thought was very interesting. But yeah, that summarizes my presentation. Hope you enjoyed it, and thanks.